I made my chair taller, so it's not cutting my chin off anymore. You can't see Moana so well. There she is. Okay, let's start with our first section. Give YouTube a little smile. Maybe it'll pick a more flattering picture of me this time. Okay, section 1 is health supervision. We do a lot of that in pediatrics. So this is well child care, section 1, health supervision. Your first objective is to recall the components of a health supervision visit for the various age groups. Those components are health promotion, disease and injury prevention, various screening tools and tests in your physical examination, immunizations, anticipatory guidance, and then making sure you take care of any special needs or special circumstances that there may be. So part 1, health promotion. We should tell them to be healthy. It's kind of the whole point of well child care. So, that includes making sure that we're talking about their blood pressure, their weight, their body mass index, sun protection, all of the things that we need to help keep their body healthy. Number 2, disease and injury prevention. Your first objective under that one is recall the most common preventable morbidities in childhood and explain strategies for prevention. So I've listed for you lots of different ways kids can get hurt. So for instance, accidental discharge of a firearm. Kids as young as 2 can pull the trigger in a firearm. So it's really important to talk to families about firearm safety. Now, how you talk to families about firearm safety is regulated differently state by state. So in some states, you're not allowed to ask about firearms in the home, but you can always counsel about firearms in the home. So I say something like, the gun in your home should be secured this way. It should be unloaded and locked and stored separately from its ammunition. So the guns and bullets should always be in separate places, and the gun should have a gun lock on it. This is really important for helping to keep kids safe. Again, kids as young as 2 can pull a trigger on a firearm. It's awesome. Awesome, Dr. Anglin. Clearly, I've never fired a gun. Anyway, the most important thing that you can do to prevent injuries is to talk about them, is to give parents guidance and counseling on the things that they can do to prevent injury. So again, asking and talking about these things saves lives. There's a whole program out there called Ask. Asking saves kids. Just like you would tell your children's friends, parents, that's a lot, that your child's allergic to peanuts, you should ask them if the gun in their home is stored properly as a parent. Now, as a provider, you should just say the gun in your home needs to be stored this way. And it's really important for you to include that in your anticipatory guidance. For all you Florida students out there, Florida is one of those states where you're not allowed to ask if there's a gun in the home. But you can always say the gun in your home should be stored this way. Okay, don't ask, just assume they have one and give the advice as such. This is the South. Lots of people have guns. Okay. Bicycle accidents. The kids need to wear helmets. It's really important. So make sure you say, if you're going to be on something with wheels, unless it's a car, you need to have on a helmet. 4-wheelers, bicycles, scooters, skateboard, those stupid Heeley shoes that kids wore 5-10 years ago. Burns. Most common burns in young kids we see are either liquids, usually sipping hot liquids get spilled on them, pouring boiling water on themselves. So counseling parents to make sure they keep those things put away. And drowning, keeping eyes on those kids when they're in the water at all times. Firework injuries, if a device's sole purpose is to explode, then a kid shouldn't play with it. And this includes sparklers, bottle rockets. I mean, if it's intended to blow up, it's not a toy. I wish I could convince more adults of this as well. House fires. One of the most effective pieces of anticipatory guidance you can give regarding safety is to make sure your smoke detectors work. Make sure you have a fire safety plan and make sure you practice it. So I always encourage parents, once the kids are old enough, to set the alarm off and make sure the kids run outside and go to whatever your safe place is. Check those batteries every 6 months. I usually say to do it around the time change, just so you remember. And just so you know, for the longest time, every time I said this, I choked up and cried because I watched This Is Us. And every time I said, check your smoke detector, I cried. Just so you know. Yes, that's a very hard conversation. Ingestions, if it's pretty, kids will eat it. This whole Tide Pod epidemic is a complete mystery to me, but if it's pretty, kids will eat it. Motor vehicle collisions, car seats save lives, okay? If you're in a car seat and a seatbelt properly secured, you're less likely to die in an accident. Pedestrian injuries, teaching kids to safely cross the road. Recreational vehicles, ATVs, kids don't belong on those at all. Trampoline related injuries, if I had my say, kids wouldn't be on trampolines either. Trampolines are incredibly dangerous. So I want to go back and pull out just a few key points related to childhood unintentional injuries and childhood deaths. So unintentional injuries in kids, the most common cause of kids less than 1 is suffocation. So something gets over on the baby's face, SIDS, the face down in the mattress. Suffocation is the most common cause of unintentional injury. In the age group of 1 to 4, the most common cause of unintentional injury in kids is drowning. Keep those eyes on those kids in the water. Always be within reach of your little kids in the water. These are my magic reach fingers. If you can't touch your kid, you're too far away in the swimming pool. Make sure we talk about that summer safety. Also, pools should always be fenced off from the house, never to the house, okay? Kids shouldn't be able to access the pool independently. Never to the house, always from the house. 5 to 24-year-olds, the most common cause of unintentional injury is motor vehicle collision. The kid turns 5 and magically they don't need a car seat anymore. This is just untrue, inaccurate information. Kids must be in the proper child restraint until they are 4'9" and 80 pounds, okay? So let's talk car seats while we're talking about motor vehicle collisions. Kids less than 2 should always be rear facing in the back seat, preferably in the center of the back seat, but if you got a bunch of other siblings, that might get kind of moved around a little bit. Rear facing, back seat, 5-point harness, always looking out that back window. That's what I tell the parents, because when I say rear facing, they glaze over. Looking out that back window, okay? Kids older than 2 can be turned forward facing, but I always encourage parents to keep them rear facing as long as you can. Once you turn them forward facing, they still need to be in that back seat, center if possible, in a 5-point harness, properly secured, making sure that that seat fits for their height and weight. You can always look at that sticker that's on the side of the seat. Usually one side's in English, one side's in Spanish. So if you have a family that speaks Spanish, you can always turn that seat around so they can read the other side. Make sure that they look at that and that they know whether or not their child fits properly in that seat. Okay, once they get a little bit bigger, once they outgrow their 5-point harness, so you got to be pretty big to outgrow that sucker, okay? 5, 6, going on 7 maybe if they're small years old before they come out of that 5-point harness, they can go to a booster. I always prefer a high back booster over a bottom only, but at some point they're going to outgrow that one. It depends on their height and weight. Again, refer to that sticker on the side of the seat. Got to be in a booster until 4'9" and 80 pounds. And at that point in time, the kid should be able to sit in the seat with the seatbelt across their shoulder, bottom flat in the seat, and feet flat on the floor in the car. In some of those big super dually trucks, that's not going to happen at 4'9", 80 pounds, okay? So in some of those trucks, smaller kids, even if they meet 4'9", 80 pounds, may still have to be in a booster seat. So make sure, again, the belt comes across the shoulder, not the neck, and their feet are flat on the floor. If they meet those requirements, then they're good to go with no booster. Keep them in the back seat. Kids belong in the back seat, okay? Their little necks aren't strong enough to deal with the airbags, so they need to be rear facing. They need to be in the back seat. Now, let's move on to talking about deaths. So less than 1, the top 5 causes of death. Number 1, congenital anomalies. That's going to be the babies that are born with very severe malformations. 2, short gestation, your preemies. 3, SIDS. 4, issues related to pregnancy. And 5, unintentional injury. So in the less than 1s, the younger they are, the more likely it is to be something related to a congenital malformation, prematurity, SIDS. Okay, the unintentional injuries don't come into play until we get to number 5. In the 1 to 24-year-olds, the top cause is unintentional injury, okay? Unintentional injury is the top cause of death in 1 to 24-year-olds. So we really need to be talking about injury prevention to families, okay? It's not childhood cancer, which we see on the TV every day. It's not heart disease. It's not anything else. It's unintentional injury, okay? So in that 1 to 4 age group, number 2 is congenital anomaly, number 3, malignant neoplasm, number 4 is homicide. Let that sit in for a minute. The number 4 cause of death in 1 to 4-year-olds is homicide. Someone took their life. Okay, child abuse. So we need to be talking about that as well. In the 5 to 9-year-olds, it's very similar. Unintentional injury remains number 1. Number 2, malignancy. Number 3, congenital anomaly. Number 4, homicide. 5 to 9-year-olds. 10 to 14-year-olds, number 1, unintentional injury. Number 2, suicide. Taking their own life. 10 to 14-year-olds, number 2, cause of death is suicide. Number 3, malignancy. Number 4, homicide. 15 to 24-year-olds, number 1, unintentional injury. Number 2, suicide. Number 3, homicide. Number 4, malignancy. So the top 3 categories in the 15 to 24-year-olds, unintentional injury, suicide, homicide. Preventable. Things that we need to be talking about and things that we need to be helping families and kids with. Alrighty, so now let's move on to intentional injuries. Child abuse. There are lots of different types of child abuse. Neglect and physical abuse are probably the most commonly reported. Emotional and verbal probably occur most commonly. And of course, sexual abuse as well. Looking at the United States, what's reported, about 9.4 per 1,000 children is abused. That's what was reported. So that's almost 1 in 100 kids is reported to be abused. Now, we know that child abuse is way more common, and that's just what's reported. A lot of times I call protective services and say, hey, I really think this child is in a bad situation, and they can't substantiate that claim. And so unfortunately, it doesn't become into the system as a case report. So that one doesn't count, even though clearly that child is, in my eyes, in an abusive situation. So this number is much higher than what the reported number is. Looking at the statistics from 2014 in Alabama, since that's where I practice, there were 17 deaths related to child abuse. 17 deaths related to child abuse. And our population of children in Alabama is about 1.1 million. In that same year, there were 8,895 reported cases of child abuse. 17 deaths from child abuse in Alabama in the year 2014. Preventable deaths. Homicide, the nationwide rate, if you look at the rate just for kids, is 2.6 per 100,000 of kids on average. Again, younger kids, it's less likely. Older kids, it gets more likely. In that 1 to 14 age group, homicide is the 4th leading cause of death. And in the 15 to 24, homicide is the 3rd leading cause of death. Homicide's still on the list for less than ones, but it's on down pretty far, with the congenital stuff really being the more common. Suicide. Based on the 2015 Youth Risk Behavior Survey, 8.6% of 9th through 12th graders reported that they had made at least one suicide attempt in the past 12 months. 8.6 of 9th through 12th graders have made one suicide attempt in the past 12 months. Girls attempted twice as often as boys, 11.6 versus 5.5, and teens of Hispanic origin reported the highest rate at 11.3%, especially Hispanic females, 15.1%, with compared with white students, 6.8%, and white females, 9.8%. 2.8% reported making a suicide attempt that required treatment by a healthcare provider. And for those requiring treatment, the rates were highest, again, among Hispanic students, with Black males and Hispanic males having higher rates than white male students. So Hispanic females are the highest risk for attempts, and Hispanic students are the highest risk for those that require treatment. 8.6% of 9 through 12 graders. And what's interesting is that the number of attempts of suicide and successful suicides has climbed in the past several years. And we can debate what that's due to, but it's an issue, and we need to talk about it. And we need to talk about it with our loved ones, with our friends and our families and our patients. We need to be screening for depression. Depression doesn't always look like depression. Depression can look like a smiling face and a happy-go-lucky, outgoing kid. So we need to make sure we're asking hard questions and screening for these things in our patient. 8.6%. Wow. Again, that's what was reported too. Alrighty, let's move on to the next section here. Recall the indications, appropriate use, interpretation, limitations of the following screening tools and tests. So let's start with the anemia screening and CBC. This is recommended by Bright Futures. Bright Futures is our guiding star of everything pediatrics as far as well child care, screening, and anticipatory guidance. You're welcome to purchase a copy of that, or I'm sure there's some available in the library. They even have pocket versions. They're real fancy. So anemia screening is recommended by Bright Futures to be done between 9 and 15 months. Limitations of that: if you've got a kid with a thalassemia, you need to remember that, and you need to remember that Menser index that's like on every board test ever, and the formula is somehow impossible for me to remember. You need to pull that back out and remember it, because you can use that Menser index to help you determine if it's an iron deficiency anemia or related to a thalassemia. Remember that kids who are iron deficient and anemic have a lower IQ at the time of testing during their iron deficiency. So it's really important that we get that treated so that they can go about learning and being happy, healthy kids. Developmental screening. I've mentioned 3 of them here, probably 3 of them more common. The ASQ, the Ages and Stages Questionnaire, has 5 components. Gross motor, fine motor, language, personal, social, and problem solving. Has about 5 questions in each category, and parents just fill in a bubble about whether or not their kid is able to do that skill. It's very easy to administer in an office setting, and I would say probably more commonly used than the Denver. Denver is a very time-consuming, thorough evaluation, probably more commonly used in the behavior and development clinical psychology setting, although there are newer screenings out there certainly. And the MCHAT is our autism screening. It's easy to use. It's like 22 questions. It's very easy to score. The version that we use in the office, there should only be 4 no's, so I can usually look at it quickly and let the parent know the score. If they miss 1 critical or 2 non-critical questions, then the child needs a referral for further evaluation for autism. We give out these screening tests at various ages. There are very specific ages specified in Bright Futures. We usually want to screen for, we do a screening at 9 months, usually starting to get an idea of how gross motor is coming along and personal social interaction. Repeat that screening around 15 to 18 months, starting to see that language emerge, starting to see them communicating more with their family. Unfortunately, the inability to communicate and tantruming also emerges during that age as well. And then we repeat the score usually around 4 to 5 before they're going to kindergarten, making sure that all those skills are coming together. Now, at our office, we do it a bit more often, but that's the standard. Screening for gross motor, 9 months, screening for personal, social, language skills at 15 to 18 months, and then making sure that we're putting it all together before kindergarten. Next one, environmental lead screening and blood lead levels. So the majority of practices just have a quick lead screening questionnaire they give out, asking about the age of the house, the flaking paint, toys with lead paint on them, or environmental lead exposures. If you're in a lead smelting area, like I was in Kansas City for residency, there's a lot of lead in the soil, so kids that lived in certain zip codes were considered high risk. Poverty is also considered a risk factor for lead exposure. So we want to make sure that we're screening for that, and if there are risk factors, that we do a blood lead level, which is easy. Some insurances do require that those are done. I know Alabama Medicaid recommends and requires those. We usually do them when we do the CBC between the 9 and 15 month visit for screening. Next up, we have the hearing screening. Everybody gets one of those at newborn because if there is a hearing deficit, we want to identify it and we want to make sure they have hearing aids in place by 6 months. In the office setting, we start screening for hearing issues at 5 years of age. Before then, they got to be able to hear the beep, raise their hand, hear the beep, raise their hand. Their processing skills really aren't formed enough before 5 years of age to get that going consistently. TB screening, again, is based on risk. If they've had an exposure, certainly we're going to screen. If they've had certain international travel, or if they're going into a healthcare-related field, then we're going to get that screening. Urinalysis used to be routinely done at that kindergarten visit, but we don't typically screen with urinalysis anymore unless there's some reason to do it, elevated blood pressure or symptoms. So urinalysis is not part of our routine screening panel anymore. Vision screening, we do this at age 4 and up. We have picture cards, or they can do the letter cards, whichever one they feel more comfortable with. Cover one eye, say the picture. We want to make sure we get any visual deficits identified before the kids go along to school. Next up, let's talk about immunizations. Explain the rationale for childhood immunizations. Well, immunizations prevent disease, so it really makes pretty darn good sense to give them. They prevent morbidity, mortality, they lower overall healthcare cost. Immunizations are life-saving, and all kids should be thoroughly, appropriately, and swiftly vaccinated as indicated per the CDC guidelines. Explain the limited contraindications to childhood vaccines. The one that I face most commonly is moderate to severe infection. So the kid comes in for their well child checkup and oops, they have a fever and it's 101 and now their flu test is positive. Well, you probably shouldn't get your vaccines today. Or their asthma's flared up and I need to put them on oral steroids. We probably shouldn't give your vaccines today. So acute illness, they classify it as moderate to severe. Now, if you just got a bug bite, you're still going to get your shots, okay? But moderate to severe illness is the most common contraindication that I face. There are others. My kids that are currently in chemotherapy or live in the house with someone who's undergoing chemotherapy or bone marrow transplant, they may be restricted on certain vaccines, particularly the live virus vaccines. Kids with certain immunodeficiencies are going to be restricted as well as kids with some autoimmune diseases may be restricted. Best to contact those children's physicians for specific instructions. Usually their rheumatologist or immunologist will be happy to provide us with clarification on what vaccines are safe for that patient. Allergic reaction and hypersensitivity are exceedingly rare, but if it does occur, then you can consider making modifications to your vaccine schedule as needed. Now, this does not mean because they get a little red swelling on their leg that they can't have their tetanus shot next time. A local reaction is not a hypersensitivity reaction, and it is not a reason to delay or avoid future immunization. Okay, your leg gets a little sore, you're going to be okay, but you're going to get another tetanus shot when you come back the next time, okay? I'm not going to let you out of it for a little leg swelling. Guillain-Barré, you're more likely to get Guillain-Barré from an illness than you are from an immunization. For instance, some people have linked it to the flu vaccine, but you're way more likely to get it after having influenza than you are to get it from the vaccination. But some people are going to ask you about that. Guillain-Barré is linked to immunizations in some settings. Incredibly rare, though. Incredibly rare. All right, define anticipatory guidance. So anticipatory guidance is a huge part of my job and one of my favorite parts. So that's where I get to assist parents or guardians in the understanding of expected growth and development of their children. So at the 4-month visit, I get to say, oh, we're going to get to eat solid food soon. How exciting. Or your baby's going to start rolling over. At the 2-month visit, best to make sure you don't leave them on any high surfaces. I get to talk about all the fun things that are yet to come for the parents. It's really fun. How it changes based on the age of the child. Well, I'm not going to tell a 6-month-old that your baby's going to start rolling over soon because they should already be sitting up, right? I'm going to say that to a 2-month-old. I'm not going to tell the parents of a 12-year-old who's 5'4" that their child needs to be in a car seat, right? You're going to look at the age of the child and base your recommendations on that. I'm not going to talk to a 4-year-old about doing IV drugs. Okay, I'm going to save that for my teenagers. Is in my sex, drug, and rock and roll talk. So make sure that we are talking about that's totally what YouTube is going to pick right there. Me scratching my nose. Fabulous. Make sure we're talking to parents about appropriate anticipatory guidance based on the child's age and if there's any special needs, which we are going to get to right now. So identify unique features of children with chronic medical conditions and special needs that should be addressed during health supervision visits. Well, kids that are born extremely prematurely, or kids that have extremely premature, or kids that have significant delays, cerebral palsy, they've had strokes, or they're have congenital anomalies, require very specialized care. And we want to make sure that we take time at their well child visits to evaluate if they need any updated referrals or new specialty visits, if they have everything that they need to keep their body safe and healthy. So if they need new orthotics, if they've outgrown them, if they need a new wheelchair fitting, if they need a new helmet, if they're a kid that has some sort of seizure disorder, do they have feeding supplies, if they're fed only by a certain bottle, or if they're fed only by a G-tube, do they have everything they need for that? Do they have any, the car seat that they need? I mean, imagine a 4-year-old with significant postural deformities may not be able to sit upright in a car seat. They may need a very specific car seat for the car, particularly if they have tone issues. Making sure that they have mobility aids. Do they have a wheelchair that allows them to get around in school? Can they get to and from the door at the grocery store? Does the parent need a handicap parking pass? Toileting needs. Are they in a diaper? Do they need cath supplies? Do the parents understand how to use a cath? Are we getting a bunch of UTIs? Are they constipated? Do we have everything we need for toileting? And of course, making sure that they're getting all of the therapy services to help them be their very best. And that's what I want for every kid, not just a kid with special needs. But if we start to see any areas that we could work on or improve, I want to make sure we get them in therapy services as soon as possible, so that we can make things better for the patient and the family. All right, so that concludes health supervision. I will see you guys next time.